Hello, everyone. I have to say good morning or good evening to all of our audience. So very welcome to the Sino-US Scholar Dialogue series on public administration. This dialogue is jointly organized by the section on Chinese public administration of ASPA and School of Public Affairs at Zhejiang University in China. So since we already have organized two dialogues already. So today is the third dialogue in this series on envisioning health policy in the post-COVID-19 pandemics. My name is Xiaoting Liu. I'm associate professor at School of Public Affairs in Zhejiang University. I'm the moderator of this session. So before the presentation, firstly, I would like to invite Professor Lu Yi from the City University of New York to give an opening remark. She is the chair of SCPA for ASPA. So Professor Lu, please.
Thank you, Professor Liu. Hello, everyone. My name is Yiling Lu. I'm a professor and the director of public policy and administration at the Jingwei College of the City University of New York. I happen to be the elected chair of this section this year, and we have a new elections is going to be running in a month. So anyone who is listening to this dialogue and is interested in serving this role, please, feel free to submit your name into the election. So as Professor Liu mentioned, this is the third in a 6-episode dialogue series that we have planned. And together with my dear colleague and a friend, Professor Zhang from Zhejiang University, we are very proud to sponsor this series. Although Professor Zhang and I are world apart, one is in New York, one is in China, our organizations share the same mission of building a better, stronger, and a more connected community of scholars. And I would urge you, if you like the activities that we are providing here, please join our section, all right? And the section's secretary, Han Jing, will share some how to join information in the chat later on. I also would like to extend my sincere welcome to our distinguished guests, Professor Eggleston of Stanford University, Professor Lin, an Executive Associate Dean of the University of Hong Kong, Professor He of the Education University of Hong Kong, and our very own moderator, Professor Liu of Zhejiang University. So thank you all for taking time out of your busy schedule to share your insights. I look forward to the dialogue. Thank you.
Thank you very much, Professor Lu. So next, I would like to invite Professor Vivian Zhang. She is the vice dean of our school. She collaboratively worked with Professor Lu to organize this series of dialogues. So Professor Zhang, please say some words. Thank you.
Thank you, Xiaoting. So distinguished guests, dear colleagues and friends, good morning, evening. Thank you from different parts of the world to participate in Sino-US Scholar Dialogue series on public administration. On behalf of School of Public Affairs, Zhejiang University, I would like to extend my warmest welcome and sincere thanks to all the guests and participants. It's great to meet with you. So located in Hangzhou, one of China's most picturesque cities, Zhejiang University is one of China's top higher education institutions, as well as one of its oldest. Founded in 2005, School of Public Affairs insists on being a leading public administration school and pioneer in digital governance in China with complete disciplines, remarkable achievements, strong social influence. Adhering to the model of world affairs as a responsibility and truth as faith, SPA is committed to excellence in teaching, learning, and research, and to nurturing leaders in many disciplines who make a difference within the nation and across the globe. Currently, we have more than 120 faculty members and almost 3,000 degree-seeking students. Besides, we provide 2 English taught master programs. One is MPA, which is accredited by NASPA. Another one is a foreign aid training program for Ministry of Commerce. Additionally, special thanks to our partners, SCPA, who work with us for several months and give us great support during this special period. So we believe that we would get together in person in Hangzhou very soon. Enjoy this academic feast. Thank you.
Thank you, Professor Zhang. So next, let me to introduce our speakers and the discussants briefly. So today we have 2 speakers, Professor Karen Eggleston from Stanford University. I'm very honored to invite her to share the recent research. She is the director of Stanford Asian Health Policy Program at Stanford University. And the second speaker is Professor He Jingwei. Professor He is the associate head and associate professor at Education University of Hong Kong. He is my friend and helped to organize this session. So thank you, Professor He. Thank you very much. So they are 2 distinguished scholars in the health policy studies. Together with us, we are very honored to have another 2 discussants. Professor Vivian Lin from the University of Hong Kong. She was the Director of Health Systems at the Western Pacific Regional Office of WHO. So the other discussant is my colleague, Professor Lin Ka. He is the Director of the Department of Social Security and Risk Management in our school. So I'm very happy to have 2 Professor Lins join our discussion today. So we are looking forward to hearing their very helpful comments and views. So the whole session will be recorded afterwards. So thank you. The first speaker is Professor Karen Eggleston. So let's invite her to give a presentation. So Professor Karen, welcome.
Thank you very much. It's a pleasure to be with you all today and to talk about these very important topics. I'm really honored to be a part of this dialogue and look forward to the discussion. So I was going to talk today about innovation for healthy aging during and beyond the coronavirus pandemic. And this is drawing from research jointly with many colleagues throughout the region. So over the years, when I've talked with students and colleagues about the improvement in health of today's now high-income countries, looking back over a century, we can see there's been dramatic improvement, and there have been times when there were significant blips in the road, significant decrease in this case of the percent of the birth cohort expected to survive to age 65. Usually students and colleagues would say, oh, that's World War I and World War II. But now we all know, unfortunately, that that first one actually is the 1918 pandemic. Right now, we're all facing the challenge of whether we will continue patterns of healthy aging with equity or not after the current pandemic. I look forward to your insights about that. With my colleague Victor Fuchs, we looked at this trend, and as you all know, Asia in some ways is leading the way for the world in pioneering this new demographic transition of very older age structures. If you can see here, starting from the beginning of the previous century, over 20-year periods, you can see the share of gains in life expectancy at birth that were realized in the traditional retirement years increased steadily. And Japan started below that average and is now well above that average, as are some of the other economies in East Asia. And so this brings a question beyond the current pandemic, this question of how to deal with what really is a triumph of longevity, of longer lives. Will they be healthy lives, and will it be equitably distributed, this triumph of longevity? Even before the pandemic, population aging and healthcare spending growth challenged universal health coverage achievements and their sustainability. So policymakers, as you know, have been searching for strategies to improve health through prevention, such as subsidized health checkups or mandatory ones in Japan. I'll talking about our research about that, to try to compress morbidity and delay onset of chronic disease, or also to encourage or nudge patients to seek care in cost-effective settings that may be more convenient, like primary care, and to enhance cost effectiveness and the value for money in what we spend on healthcare. So I'll touch briefly upon those. The COVID-19 pandemic has accelerated some of these trends and slowed other ones, and we'll be talking about this for many years to come. I don't pretend to have any of the answers, and I look forward to the discussion about it. But we do know that health systems are far more than universal health coverage, and they're deeply interlinked with the economy. That's something that's taken for granted in the past, and now is well known that our very social lives are underpinned by controlling infectious disease and having resilient health systems. And then it goes beyond healthcare to transparent governance and broader economy and society guided by science, including collaborative governance, harnessing the best of public and private sector. We need to innovate for social and economic policy, not just on the pure technologies. And this economic downturn is straining financing for social protection right when they are needed most. So the question is, will this reverse the earlier trends toward healthy aging and efforts to reduce inequities? So I thought I'd talk a little bit about collaborative research with colleagues, providing a glimpse into the impact on vulnerable groups, particularly those with specific chronic diseases like diabetes. And then talk a little bit about collaborative governance, as I mentioned, about leveraging new technologies to close health disparities, try to restore trends in healthy aging, innovate to build resilient health systems, but it requires careful regulation and management of what we sometimes call payoff discretion by private sector and transparency. Finally, I touch upon improving the value, not just controlling costs, and strengthening primary care. So with colleagues in India and then across other parts of Asia, we had harmonized surveys going out to cohorts of those with diabetes and other chronic diseases in 4 sites in India. Some of that is published work, and then we have comparative work with other sites. In India, there were 4, as mentioned, quantitative and qualitative interviews. We have a site in Jiangsu and in Shanghai, in Hong Kong, in Korea, and in Vietnam of different sizes and representativeness last year through January of this year. So in the qualitative interviews, and this was in the first wave in India, we talked to patients that were suffering from diabetes or hypertension about their experiences. As we know, there was a lot of avoiding healthcare, even if it might have been needed, partly because beds were not available even in some places during the first wave of the pandemic, much less the second one, or there was fear of being exposed. It's less clear whether this was delayed care or foregone care entirely, and what the longer term implications of that will be. And I look forward to working with colleagues on that. There were also some hints that telehealth may have helped to mitigate some of those impacts, but again, we'll need longer term evidence to see to what extent, especially, they were able to reach the vulnerable. In our quantitative survey, we found that rural participants were disproportionately impacted, and that financial aid from the government had a protective effect, but it was not completely able to mitigate the impact of reduced access to medications and loss of income, such as losing jobs during lockdown. This figure shows you that all of these trends were worse in the rural as opposed to the urban areas in India that we surveyed. When we looked in a multivariate framework at factors associated with difficulty in accessing care, we found that rural areas, again, were the most likely to have difficulty in access, and those that experienced loss of income. We also looked at whether individuals felt that their symptoms were worsening from diabetes or hypertension or other chronic diseases. And again, we found that having difficulty in accessing medications was an important factor, and that other ones, even when you control for difficulty in access, such as experience loss of incomes, also contributed to worsening of outcomes. We did comparative research in other selected sites as possible, and we found a significant proportion of participants reported increased difficulty in accessing medical care or in obtaining medications to control their chronic diseases in the percentages reported here. Also, individuals, a minority, but a substantial vulnerable group, reported worsening of symptoms related to those difficulties in access or foregone or delayed care. We did multivariate regressions here as well, and the results are somewhat similar to the ones that we showed already for India, so I won't draw on all of the details, simply to say that those also that were surveyed in rural areas of China reported worse outcomes, and those that had a worsening of their economic status because of the lockdowns or overall economic slowing. In the studies on India with colleagues, we put together some recommendations to try to build more resilient health systems going forward. I list those here. Again, I won't go through them all, but just to mention that my colleagues felt that this crisis might give us the opportunity to rethink the current systems and to try to build an effective transition to a system that, for example, built on innovative digital healthcare solutions to try to reach those vulnerable, both with self-monitoring of their chronic conditions and enabling cost-effective primary care. This would also include redesigning care delivery models, though, to support those trends in healthy aging. Next, I'll talk a little bit about collaborative governance, as I mentioned. I've been working with some colleagues on the conceptual foundation and had the honor of interviewing many other fellow health economists in light of a quarter century of a famous article entitled The Proper Scope of Government by Oliver Hart, Schleifer, and Vishny. And their colleagues from Asia and other parts of the world reflected on those conceptual underpinnings and how they might guide us going forward to think about more resilient health systems and trying to regulate the bad behaviors and improve the productive behaviors, both technically, institutionally, and socially across health systems. That documentary is available if you just search YouTube for Proper Scope of Government, and there's sections specifically on COVID pandemic and response. I also had the honor of interviewing Oliver Hart, the Nobel Prize winner and co-author of that study, reflecting on a quarter century of that proper scope of government and thinking about contracting in the health sector and how the incompleteness of our contracts and other market failures circumscribe what can be achieved, but still the important role of thinking about what should and should not be produced directly by the government rather than contracting out to the private sector. Separately, in conjunction with colleagues Richard Zeckhauser at Harvard and Jack Donahue, we recently published a book, The Dragon, the Eagle, and the Private Sector, where we talk about this government working with the private sector and this delegation decision tree about should the government be involved at all? If so, should they produce a service directly, or should they delegate and work with the private sector in terms of delivering specific services? Those could range from healthcare services towards public health outreach and so on. But even after those decisions have been made, they have to be reanalyzed periodically with transparency to make sure that what we're spending and our arrangements are actually achieving outcomes for the public good. And there are many international collaborators to try to leverage public and private sector and international organizations. Our discussants know more about this, and we'll talk about it. I just wanted to highlight here that is also an important aspect of collaborative governance is to try to draw from productive collaborations in innovating quickly and trying to reach equity going forward. Finally, I talk a little bit about efforts to improve health through prevention. In Japan, they tried to mandatory screening. We, with colleagues at University of Tokyo, Toshi Iizuka, we tried to evaluate whether this was having an impact. And we find that the marginal value of information differed. Using a regression discontinuity design, we find that for the general population, whereas health warnings after a checkup focusing on diabetes, they increase healthcare utilization, but they do not really improve health a year or more afterwards. However, if you focus on the highest risk group, they do improve their outcomes and the improved health is worth its cost. So that's suggesting that simply requiring health checkups is not going to change everyone's behavior, but it can be an important part of the puzzle if well targeted. These are the results. The top panel, you can see that although there was an increase in utilization, no change in fasting blood sugar for the general population. But if you focus on the high risk, the bottom panel, you see again an increase in utilization when their fasting blood sugar is above the clinical cutoff and they're told to go see a doctor, and a fasting blood sugar later is better, suggesting that it might have been worth it to see the doctor, and we show that in the paper. I did other work in collaboration with others in Hong Kong, Japan, and elsewhere, looking at quality adjusted medical prices for chronic disease. And we think this is something that going forward, we may need to continue to invest in to try to understand how we can improve value, not just control cost. But there's little evidence on whether spending is worth it, and this kind of research can help give us that kind of evidence. Whether our spending is producing better health outcomes of commensurate value with our spending on those outcomes. This is a critical question for understanding value. Without such evidence, cost control may stifle valuable innovation rather than just reduce inefficiency. So we studied this with data on over 120,000 patients from these 4 health systems, and we found encouragingly that the value of improved survival outweighed the added costs of care, even though spending is going up. So we need to have additional research to try to understand whether there's value for what we're spending going forward. And I think this is a method that many can try to utilize. Indeed, I'm hosting a virtual workshop in February after Jingwei, if anyone wants to join, with David Cutler from Harvard, Abe Dunn from the US Bureau of Economic Analysis, and others, to look at innovation of public administration in the sense of measuring the value of medical spending. Finally, I just want to say we want to strengthen primary health care. I had the privilege of doing some research jointly with colleagues in Zhejiang. That's why I'm delighted to be talking with you all and hosted by Zheda in part. This is research joint with the Zhejiang CDC, looking at a particular county in Zhejiang, Tongxiang County. And we find that there are encouraging signs from trying to promote chronic disease management in primary care. We put together data sets from many different sources, looking at over 70,000 individuals with primary healthcare management. And we use a kind of boundary design to try to tease out causal effects, both on healthcare use and on health as measured by blood pressure and blood sugar. And we looked at townships that have different amount of intensity of their primary care management, and specifically focused in on villages that are within 2 kilometers of each other, but managed in different townships. Long story short, what we found was rather encouraging using this unique administrative data and the boundary design to try to evaluate the causal impact of the program. We found that the effect of being in a more intensively managed primary health care area led to more primary healthcare visits and fewer specialist visits. That's in outpatient departments of hospitals, like at the county hospital or urban hospitals. And importantly, 11.7% lower likelihood of having an inpatient admission and overall lower medical spending. So this is suggestive evidence that the primary care management might be working. And indeed, we find that one of the ways it might be working or mechanisms was through better adherence to medications to control those chronic diseases. And if we do a simple kind of welfare analysis, we find that the benefit just from cost savings from fewer inpatient admissions outweighs the costs of this public health investments. It's part of the essential services program that is targeted on chronic disease control. So the value would be even greater if it accounted for improved survival and quality of life. That's encouraging because, as you know, one of the issues in China and in many other places is that primary care is relatively weak and patients don't necessarily trust it. So if we can strengthen primary care, we may be able to build more resilient systems going forward. So to quote one of our discussants, we may need to accelerate innovation such as digital health and strengthen primary care to use this opportunity of the crisis to accelerate positive changes. And to know that they really are positive changes, we need to work together to provide policymakers with evidence about what's working. We also need to support our caregiving staff that's been very stressed during this pandemic. Here are some ideas about healthcare teams and how they can think about things going forward. I'll just close by focusing on another issue about leveraging technology that I've been doing some work on, which is the use of robotics in healthcare and in long-term care for the frail elderly. We know this too has come to the fore during the pandemic because of the need for social distancing and the way to extend healthcare during this time using these technologies. But in Japan and some other places, there's been development of robots pre-pandemic, indeed subsidizing of robots in Japan for long-term care to address the other challenge that I started with at the beginning, which is the demographic change and population aging. And joint with colleagues, again, Toshi Izuka at US Tokyo, we've been looking at this issue, the subsidizing of these kinds of long-term care robots in Japan, and whether that's been helping to address the big issue in long-term care, one of them being that the caregivers are very stressed, there's high turnover, there's high back pain. So these kinds of robots might be able to address some of those issues. I won't go into any detail. We happen to be interviewed on the Freakonomics podcast if you want to listen to it there or to see our working paper. More evidence is needed going forward about the impacts on staffing, but there is some preliminary positive evidence that it's not just replacing workers, it's actually complementing workers and helping them to have less burden of care in this particular context. We need to help our workforce prepare for these new technologies and to leverage them. So thinking about robotics and artificial intelligence, I show here a metric of how occupations are going to be impacted by artificial intelligence. Economists have put together different metrics based on very specific analyses of the tasks that each kind of worker in an occupation needs to undertake, and whether robotics and AI can help to do any of those tasks. You can see some occupations, such as arts and performers, are not supposed to have much of an impact. They're the lowest scoring on these scores. Focus maybe just on the red bars here. And other occupations are going to have a huge impact. The highest scoring in this case is in engineering, but I put in the middle health occupations of various kinds. And you can see even nursing aides and long-term care will have some impact, as we've been finding in Japan. And radiologists are going to have a huge impact, and surgeons. So we need to be preparing our workforce, figuring out whether technology is helping the vulnerable and whether it is cost saving, or at least not increasing costs more than the value that they're bringing to our caregiving workforce and to our patients. So I will close there. Thank you very much, and I look forward to the discussion.
Thank you. Thank you very much, Karen. The chronic disease control has become the principal health problem in modern society, including China. So I think chronic disease is one of the big risk factors of the disability and mortality, especially the COVID-19 pandemic impact the health disparities for NCD disease, I think, patients. So I'm quite impressed by your comparative perspectives, and you are so familiar with Zhejiang and China. Hope to have further collaboration with you. And the innovation for healthy aging is very important, especially the application of robust and AI technology after the pandemic. So Karen's presentation inspires us to rethinking of the public-private collaboration on the innovation of health policy. So thank you very much. So if anyone of the audience had questions or comments, please type into the chat box and I will collect them and give a response during the Q&A afterwards. Now we move to the second speaker, Professor He. Professor He, please.
Yes, thank you, Xiaoting. Thank you so much. And it's such a great privilege to be speaking together with Professor Karen Eggleston. And I am a long-time admirer of her since I was an undergraduate student. And Professor Vivian Lin was the external examiner of my PhD dissertation 10 years back in Singapore. And I look forward to being examined by Professor Lin again. So let me share my screen. So this is the paper I'm going to present today. First of all, let me give credit to my co-authors, Professor Azad Bali, based in ANU, and Professor Amr Mesh in National University of Singapore. So we collaborated on this paper to really trying to consolidate the public policy knowledge theories to explain how COVID-19 is going to change the health policy landscape. So in this paper, we do not take a public health approach, and it's certainly not a health economic study. In this paper, we will be mainly speaking the language of policy sciences. So some of you may feel the language I'm going to speak alien, but hopefully interesting. So last year, the European Observatory of Health Systems and Policies published a fantastic policy brief in strengthening health systems resilience. And in this paper, they put forward a concise but illuminating model. They describe it as stage of policy of a shock cycle for health systems. In stage number 1, all health systems are expected to be fully prepared for any pandemics, for any public health emergencies. And stage number 2, the shock onset and alert that describes what we experienced and what most health systems experienced in the first quarter of 2020. And then in stage number 3, the shock impact. Everybody feels the shock impact, and national governments and all stakeholders started their response. That described the situation probably from the second quarter of 2020 until now. And then when the vaccination rate has been improving, when herd immunity, the effect of herd immunity is being found, we are probably, most parts of the world, probably entering a recovery and a learning stage. If you use Google Scholar, to Google COVID and policy, you will find lots of, studies, trying to draw lessons and learning and cross-boundary learning lessons from other jurisdictions and so on and so forth. So hopefully, I think it's time for scholars in both public health, the medical science, atmosphere, and and the medical science domain and social scientists working together to to draw some useful lessons in terms of how we can get better prepared for future pandemics and how healthcare governance can be strengthened. So, and the kind of brief landscape overview, health policy is certainly one of the health policy sectors that bears most of the brunt of the COVID-19 pandemic because health policy compared to other policy sectors is most proximate to the pandemic. So majority of the health systems all over the world have seen unprecedented devastation, right? The running short of PPE, face masks, and the ICUs are fully occupied and so on. So, and then recently the World Health Organization estimated that at least 180,000 health workers in the front line lost their lives because of the pandemic. And more importantly, this pandemic has fully exposed the entrenched fault lines within most healthcare systems, even including those which were believed to be best prepared, especially the US and some European countries, right? And many health systems, are very weakly prepared and with low with low surge capacity, and unequal financing and unethical behaviors are widely found in the private sector as well. We do know these problems before COVID-19 hit, but the long-term and the gravity of the problem and the long-term consequences, have been felt like never before, right? So the central question this paper aims to answer is, will the COVID-19 pandemic change the trajectory of healthcare policies worldwide, especially for national healthcare policies? So we really like this new metaphor, policy accelerator. I think just now, Professor Eggleston also used the word accelerating or accelerator to describe the impact of COVID. So if you look at other policy sectors, COVID has indeed accelerated lots of needed, changes, needed reforms. But at the same time, we know health system is very path dependent, right? It's very, very path dependent. And, other people, worry that after a while, after this new normal is being accepted, probably the health systems will run their business as usual. We don't know. So a little bit of the, policy sciences theories. One of the core missions of modern policy sciences is to explain policy dynamics, especially policy change, why policies change and why they don't change. So there has been a large, theoretical consensus that policy change, especially substantive policy change, is rare and it's hard and infrequent. Charles Lindblom, I think 60 years ago, put forth the incrementalism, modeling through and so on. And historical institutionalist scholars also use the concept of path dependency to describe why policies don't change, why institutions tend to be sticky, right? And in policy sciences, we have other metaphors like policy styles, policy paradigms, to explain policy stability and why policies don't change. And if you zoom out to see, to resort to the kind of the broad social science theories, there are more explanations. For example, ideologies, material interest, political institutions, and the policy feedback literature is particularly useful to explain why policy change is rare, because policy feedback mechanisms can, very vigorously lock in through a variety of mechanisms to lock in the status quo, making policy change difficult. And then when compared with other sectors, health policy sector is very peculiar because change is even harder. Number one, because there is a great deal of material interest. The pharmaceutical companies are very powerful, right? And then they have very strong lobbying power. And then you see the commercial insurers and the medical professions and so on and so forth. And very peculiar in the health policy domain is the doctors. They are very powerful. And of course, many of their activities, are done under the basically disguised by the so-called professional autonomy. And Professor William Xiao in Harvard used the word a medical axis of power to describe the vested interest of doctors. They essentially possess something we call veto power. because no health policy reform could ever succeed without the cooperation of these frontline troops. And then recently, scholars in public policy have been using policy feedback theory to explain why changes are difficult in policy, in most policy sectors, including healthcare. For example, NHS in Britain and Medicare in the US, and the social healthcare insurance programs, there are several, dominant mechanisms, feedback mechanisms, which together strengthen the existing policies and reproduce their logics. So having said that, substantive policy change is not entirely impossible because there are several, explanations. Existing policy patterns can be disrupted despite path dependency. Existing dependencies can be disrupted by something we call focusing events or punctuations. For example, John Kingdon and Baumgartner and Jones, they have put forth several, useful explanations. For example, exogenous shocks, especially crisis, they can serve as critical junctures to break down, path dependency and then create a favorable condition to make policy change possible. And 10 years ago, David Weisfeld has, written a very enlightening paper. Let me quote what he said. On rare occasions, a perfect storm arrives on the policy landscape, and a juncture of large scale and exceptional character opens a window for something big and new. And here, I think he was mainly referring to policy entrepreneurs, because no major policy change could ever happen without active human agency, without the promotion of, individuals. So, for example, Barack Obama certainly played the role of policy entrepreneurs, in Obamacare, Affordable Care Act, right? So health systems are highly interdependent because it's very technically complex. For one thing to change, you have to change other things. So basically, this creates something called a policy gridlock. There are so many problems and so many components within the health system. Problem A, you want to solve problem A, and then you have to solve problem B at first. And then the resolution of problem B relies on finding a solution for problem C. So all these problems are intertwined. So making a reform, making major change, extremely difficult. So in this paper, we mainly zoom in to look at 5 major health system functions: governance, financing, regulation, payment, and provision. And the context of our examination is mainly in Asia. So we first look at governance. So before COVID hit the world, actually, we have already seen a very salient reversal of the trend of decentralization and marketization. And these kind of marketization reforms started mainly from 1980s, promoted by New Public Management Movement, NPM. And however, after 20 years of operation, we learn more lessons than good experiences. So from, in the past 20, 30 years, policymakers and scholars have recognized the limitations of NPM and marketization. So the role of a stronger role of government, of the state, has been expected. So WHO has been very active, has been very actively promoting a new concept, which is stewardship. And that concept truly highlights, emphasizes the role of the state, especially national government, to articulate strategic vision. What do you want to deliver to your citizens? Right? Setting minimum standards and devise strategies to meet these goals and mobilize resources to achieve, overarching health system goals such as universal health coverage. So while decentralization is certainly needed to account for the subnational disparities and so on, we do need, people have realized that certain sort of centralization is also necessary to really combine both central oversight with local innovation and the initiatives to sort of strike a balance. For example, if you look at the case of China, the Chinese healthcare reforms in the past 20 years, especially past 10 years, have made significant improvement. And then the dual steward structure has been formed. On the left-hand side, you have the National Health Commissions restructured from the Ministry of Health. Then the newly established National Healthcare Security Administration now is playing the role as the single, purchaser, and has been very, exertive in terms of, being the third-party purchaser of health services. So basically, the landscape health governance was already changing towards, strengthened government role before COVID. And when COVID hit the world, mainly because, this disease, this virus is very fast spreading and is transboundary in nature. So that requires a strong central authority to devise and coordinate the national response. So in both federal states and unitary states. So we have seen lots of health governance mechanisms, for example, high-level interministerial task force, national command centers, central steering groups. All these sort of health governance mechanisms have been put in place to fight COVID, right? So when we look at the post-COVID landscape of health governance, we feel that the trend we observed before COVID is likely to accelerate, because the demand for centralized coordination are truly real in most countries. And the measures most governments have been taking already began 2 decades ago. And more importantly, the new normal. We have to be prepared for the new normal. The new normal truly requires very concerted coordination between the health system and many other socioeconomic sectors. For example, the resumption of work, reopening borders, right? Like, travel restrictions and so on. All this requires, very close coordination between health system and other systems. However, in the meantime, we must draw some caveat. That is, majority of the countries, especially those larger countries, it's very difficult to really accommodate, high disparities, right? The interests and objectives of different governments are diverse, and it's, pretty hard to bring under a common framework. So the next domain we examine is provision, how health services are provided and organized. So I think if you look at the pre-COVID health service provision, the most remarkable trend was the shifting boundary of the public-private mix. For example, this trend was very evident in Asia from 1980s to 2000, promoted by new public management movement. We have seen a dramatic expansion of private provision in China, particularly India, in Indonesia, Thailand, including Singapore, and many parts of East Asia have become international hotspot for international medical tourism, right? Welcoming wealthy patients from North America, from Australia, and from Europe. However, the 1993 Asian financial crisis somehow slowed down that trend, right? And privatization was also slowed down in China and Singapore. This is largely in recognition of the adverse consequences of private provision, because of the vast equity issues and accessibility issues have been recognized. And then, so in the past 20 years, we have seen a very strong trend towards strengthening public provision, right? More fiscal investments have been made, structural reforms have been launched, accountability mechanisms strengthened, and so on. So in COVID, in the past 2 years, obviously, in most countries, the national level response heavily relies on public hospitals, the public sector, as first responder and as the main care provider. And in the meantime, on the other hand, lots of the dark side of private provision has been fully exposed, right? We have seen lots of reports, about the scandals involving private hospitals in India, South Africa, Nigeria, and many parts of the world, for example, denying services to COVID patients, sorting patients based on affordability, right? And gaming the government and so on. So all these unethical behaviors have really undermined the legitimacy of public-private partnership, especially undermined the trust among the citizens. So, and on the other hand, we must be fair to private providers because they have to hold their business bottom line. So they're simply not incentivized to invest in slack capacity and public health related services, especially infection control. This is too much for them, right? And then, so looking forward, in this paper, we argue that the emerging trend of strengthening public provision is likely to accelerate, right? Because the value of public provision has been recognized like never before. But in the meantime, we do note the challenges, right? The challenges remain. For example, despite the huge investment, huge government funding put into the public sector in many countries, the cost effectiveness of public provision remains low, right? Operational efficiency of many public hospitals remains, limited, and staff morale and lots of perverse incentives remain there. So structural reforms of public provision, is still very much needed. So that is provision. And thirdly, we look at financing, affordability, right? Raising fund. So before COVID, we have seen quite strong evident trend towards increasing public funding and the expansion of social health insurance in Asia, right? Since 1990s, China has, especially 1999, China started its reform towards, social health insurance. And basically in less than 20 years, the majority of Chinese have been covered by at least one of the current 2 social health insurance programs. And Thailand launched the very famous 30-bar program, universal health coverage, and India's National Rural Health Mission. And then India also launched its social health insurance system as well. So we have seen a very robust stride towards universal health coverage in Asia. And then in the meantime, many governments in basically recognizing the limitation of social insurance financing, many governments have been offering subsidies, to poor households. For example, in China, India, Indonesia, Vietnam, and Singapore, government subsidies have been paid, to really mitigate the equity and equality issues in healthcare financing. So COVID, the impact of COVID on healthcare financing is also very clear. Most remarkable trend is that government spending has been significantly increased. For example, public spending on health doubled in India and in Indonesia. So most of the additional funding has been channeled to strengthening preparedness, public health preparedness, ensuring access to vaccinations, right? And filling up the gaps in public health infrastructure and so forth. So looking forward in this paper, we largely anticipate that the increase in public spending is likely to accelerate. And we also anticipate that the reliance on non-contributory financing is also likely to accelerate. Why? The chief reason is the increased expenditures in the past 2 years they are actually responding to some enduring needs, especially vaccination drives and strengthening disease surveillance and reporting. Most of especially in the forthcoming new normal, these needs are enduring and long-lasting. And the political economy will also tell us that health expenditures are tricky because they tend to be sticky. Once they are being allocated, it's very difficult to remove them or to take them away, right? So because the value of non-contributory financing is recognized like never before because of this unprecedented pandemic. So the fourth domain we examine is payment. Payment is certainly very, very significant for health system. So before COVID, we actually have seen a salient expansion of prospective payment mechanisms in Asia. And fee-for-service, which dominated the payment mechanisms, has been recognized as because it's very cost inflationary, right? And for the sake of cost containment, fee-for-service has to be reduced. And many Asian countries are moving away from fee-for-service towards more scientific and cost containment oriented payment methods. For example, capitation, DRG, and global budget. So moving forward, in post-COVID era, we argue that the importance of fee-for-service will further reduce because it's simply untenable in treating COVID patients because of the magnitude of the financing required. And then we also feel that at the same time, many insurers, in order to hold on to their business bottom line, in order to break even, they have imposed caps to payment as well. And many poor households have been impoverished because of the lack of health coverage. So in the meantime, DRGs have been very, very popular, payment methods in Asia and beyond. And but it's very difficult to set the DRG payment rate. And coincidentally, COVID, because of the standardization of COVID treatment protocols, setting scientific and sensible DRG rates have been likely and is actually underway in some systems. So in the foreseeable future, we anticipate more moves towards a hybrid payment regime, and that trend is likely to accelerate. Regulation, this last part, certainly healthcare needs lots of regulations because the stake is life and death, right? So in the pre-COVID era, we have seen rapid growth of health regulations. And for example, the safety of drugs and the medical equipment, the FDA, right, the accreditation, licensing, and so on. But in the meantime, we do recognize the tension between the regulatory attempts and resistance from the medical professionals, right? So in the past 2 years, we have seen so many health regulatory efforts, requirements, right? For example, social distancing, quarantine, travel restriction, price setting, vaccines, insurance payments, they are all put there already. And in the post-COVID world, we anticipate the growing needs, the growing use of regulations is likely to accelerate and is likely to continue as well. But in the meantime, we do recognize that in countries with a dominant private sector, South Korea, US, and so on, private providers are too large and too powerful to allow regulations to significantly undermine their profits. So how to explain this? We will need political economy knowledge. The sheer medical sciences cannot explain all these things. So to wrap up, we argue in this paper, that the crisis and other focusing events, yes, they do temporarily remove the barriers for policy change because they can consolidate societal agreement, the consensus, to address problematic issues, right? And temporarily, reduce the resistance from some vested interest. But overall, we tend to offer sobering account for the recent changes in health sector. In the 5 aforementioned health system functions, overall, we find that the pandemic merely accelerated many of the ongoing reforms which are underway for 20, 30 years before COVID hit. They started well before the crisis. And most of the changes we have summarized before are merely a recalibration of the existing policy tools. So they do not constitute an introduction of major policy changes. We have not seen really, paradigmatically different policy changes in health sector. So we overall argue that COVID merely serves as a policy accelerator. It drews, policy, COVID-19 has drawn stark attention to the shortcomings of, the usual way of doing things, right? The pre-COVID health system arrangements. And they do provide a sort of favorable political conditions for addressing the problems, but these sort of momentums are simply not sufficient to overcome the vested interest and the forces that entrench the health system for so long. So overall, we re-engage the policy sciences literature and argue that crises are truly important. They do open the policy window for change, but crises alone are simply insufficient to overcome the titanic vested interest in health sector, unless there are energetic, powerful policy entrepreneurs who can take advantage, really exert human agency, and truly push through desired reforms. But unfortunately, I think most policymakers and policy entrepreneurs are still wrestling with COVID response. So we are not yet, seeing some, sort of entrepreneurial reforms in the health system. So I think this is the last sentence. So the general conclusion of the paper is that the COVID-19, has all of the features of a so-called path clearing event. It has succeeded in, only accelerating current changes which are underway for 20, 30 years, but they have not initiated any new substantial reforms. With that, I conclude, and thank you for your attention.
Professor Liu, you are muted.
Okay, can you hear me?
Yes, now we can.
Okay, thank you very much, Professor He. So we learned a lot from your presentation. Indeed, we have to face a lot of challenges triggered by the COVID-19. Thank you very much for your 5 dimensions of the framework to rethinking about the health policy reform in the post-pandemic area. So again, if any audience have questions, please put them in the chat box. Now let's invite our discussants. The first discussant is Professor Vivian Lin from Hong Kong University. She has very rich experience both in the health policy studies as well as the policy implementation. Professor Vivian, please.
Thank you so much for the opportunity to be part of this conversation. And thank you, Karen and Alex, for very stimulating papers. I think the papers have really illustrated how COVID has exacerbated some problems and revealed the fault lines. At the same time, it's also accelerated some, I would say, quite positive trends in terms of health policy and health systems. So then the question is, what's really the potential opportunity for reform at both the micro and the macro level? And my answer to that, in a sense, depends on which side out of the bed I get up in the morning. Am I an optimist today, or am I a pessimist today? That I think that my general inclination is to agree that change and innovation is more possible at the micro level than at the macro level, unless there is not only political will, but institutional imagination for health system transformation. But let me elaborate on some perhaps additional points, on both related to aging and NCDs and to health policy change and the role of government. I think the aging and NCD issues are so important in the region because the rapid rate of aging, NCD as the #1 cause of death, the disconnect between the health and social sector that we see in so many countries, and really insufficient development of, I think, preventive programs. And of course, these have been revealed in aged care settings, in particular, in terms of the infection and death rates from older people and the constrained NCD and other non-COVID services. I think Karen brings out really well some of the post-COVID opportunities, particularly in digital health, but to really be successful in the uptake, I think we need to think more about how do we actually support the community in adapting their behavior, particularly older people who may need more support to take up the technologies. And we do have, I think, interesting examples from Japan ahead of many other countries. But healthy aging is really more than aged care and more than treatment of NCDs. So to think about maintaining functional capacity and independence involves not only the preventive services and people-centered community services in both health and social sector, but we need to do much more by the way of healthy public policy. Our housing policies, our social protection policies, indeed, the nature of urban form and urban development and transportation. And here, how do we get these Asian mega cities to actually have neighborhoods which are age-friendly? I think remains a little bit of a challenge in many places. And also to really connect the community care, whether it's non-government organizations, private sector, public-private partnerships, and to make all these changes actually does require some shifts in community attitudes, as well as the practices and attitudes. So shifting the mindset of decision makers, the providers, and the communities will require a much larger conversation in the community. But it will also need perhaps some rethinking of the financing. And how do we change the financial incentives to change the behaviors of providers and the managers? But to do that may require some changes in the education and socialization of, in fact, the health workforce and the health management workforce, if not other sectors as well. So I think this is a kind of a longer term agenda that we need to create a much more coherent whole of government, whole of society approach. And of course, we need to think about the financing of different models for now and into the future, as we see countries that are perhaps aging before they become rich. And to make these happen, I mean, I think as Alex has illustrated, it is informed by history, it is informed by a much larger context of how systems have been structured. And it is rare that we actually get the reform rather than simply a continuation of the present. So how do we actually get reforms to happen? You know, do we just hope that some of the trends that have been accelerated by COVID, or can we push it any more quickly? Reforms happen when there are newspaper headlines and scandals. Reforms may happen when the community is sufficiently discontent that it calls into question either the legitimacy of existing decision makers or existing political parties. And I think it's rare that we actually get the political leader with the will and the vision. So I think this goes back to the question of how do we actually get this community momentum for change? Now, COVID has revealed a lot of fault lines. There are community conversations about the problems facing migrants, the people who are insecurely employed. But in the Asian context, how much of this response to the equity issues will be a small programmatic response, or it will be a welfare and charity type of response? Because I think in many ways, a lot of Asian countries do not necessarily have a very strong orientation towards universality in the way, let's say, the Australasian European social democracies do. And when we think about the kind of health system fault lines, whether it's the pressure on the health workforce or a variety of other services, or the need for additional service such as mental health, how do we actually start to really shift the model of the health system, even at the micro level, when we know oftentimes it takes some funding to get innovation to happen? But we do hear that treasuries, ministries of finance are saying we've already put so much money into the health sector over the course of the pandemic. And the physical pressures will absolutely be there when there's other conversations about a green recovery, and rightly so, about a well-being economy that invests elsewhere. So where does this health system fit in this larger conversation? And should we be talking only about a healthcare system, or should we be talking about a system for health? And we had already seen in China the shift from the 2009 health reforms, which was very much about the healthcare system, to Healthy China 2030, which is about a system for health. But in different countries, whether we are recommitting to UHC in a narrow sense or doing preparedness for health security, again, in a very narrow sense, depends on the kind of demands on government to make choices. It's a matter of political choice. Now, in some countries, perhaps where there's a stronger orientation towards universality and social solidarity, we might expect much more investment in a more universal approach to recovery. But I think maybe it would be interesting to have a conversation about the Asian governance culture, where we see what I would call a strong patriarchal, you manage like it's the large extended clan. And people who are not part of your clan are not necessarily looked after, even if we believe in a strong government that looks after members of the clan. So I think that there is an issue about the political culture. And what does the notion of stewardship mean in different political cultures? And indeed, when we're also up against the power and politics of the medical industrial complex, who can be extremely powerful. So I think going forward, we need to assess the constraints on change, such as political economy that Alex has talked about, but also the opportunities for change in terms of community and leadership across different sectors, and look at how do we actually facilitate and create the pressure for the positive change, and look for the right entry points in different countries where we can reflect the citizens' voices in the governance arrangement, and that bring towards perhaps a more stronger, a more equitable framework. And that we can look at value as being more important than cost control. But for the moment, so many of our governments in Asia, indeed not just Asia, take a narrow view that what they need to do is manage the budget and look at outcomes. So from that viewpoint, I think the issue is let's get the micro changes to happen widely that we can get to a tipping point of critical mass to then get the system change. Think about how we can bring the external organizations to create, learning opportunities. The UN system is talking a lot about futures. Can we get more scenario planning into systems to bring stakeholders together to reimagine the future, and a future that would also require some institutional change. And then look at these long-term trends. And I think Alex has talked about the long-term trends. So it's a matter of how do we actually move them towards more transformational change, rather than allow the tendency of the system to fall back into existing habits, and let the second law of thermodynamics dominate. So let me finish my comments there. Thank you.
Thank you, Professor Lin. A great discussion. So the two speakers can think about how to respond later. So next, we would like to invite another Professor Lin, Professor Lin Ka from Zhejiang University. Professor Lin Ka, please share your comments.
Okay, thank you for the invitation, and I'm very appreciated to have the as a discussion with the speakers. I think that two speakers gave us a lot of information, and their presentation is informative and inspiring for the audience. And especially the first speaker, Professor Karens, presented several research made by her and in different subjects. It covers very well about the health aging and the public policies. And she reformed some key issues like the value of the health policy and the equal access, and also the dignity health, we call that a smart health, and also talk about the quality of life, how to make the health provision as valid for everyone. So for us, when we talk about public administration, the most interesting thing for us is she mentioned a key concept about collaborative or collaboration governance. We hope she can talk more about this idea, how to deal with his argument about the value of the public health and in relation with this collaboration governance. I hope that in the discussion, following discussion, she can make more, address more sense. And the other speaker is from Professor Jingwei here. That I'm very happy to meet with you in this occasion. We are the old friends. And he gave the presentation with a theoretical background, backup as the neo-institutionalism. And he gave the good introduction about this neo-institutionalism, such as the critical conjunction and the path dependence, and also term points. That is a study of the neo-institutionalism. That is a key concept. And he mentioned that he used a very clear framework to analyze the COVID-19 by governance, several keywords, by governance and the provision, financing and the payment and the regulation. That is a very clear framework to analysis. And he made a very good design about the research, and in the format that pre-COVID events and post-COVID events, and to analyze from these 5 dimensions to talk about this issue. I'm very pleasure about his presentation and the very clear conclusion, his view and his conclusion. But what's interesting for me is I trying to ask the question about how evaluate this post-COVID-19 effects. When the government or in different countries, when the government deal with this emerging issue, and of course it's very natural that it's dealing with the state power and with stronger public or state intervention as the crisis management. So this is what's going on now. But when we focus the future, or what's the past, then we have to think about the economic. In the view of the public health, perhaps we can direct the future development with a more generalized public provisions. However, we should also aware the challenge of economy, because now in the world scale that we can see there are big problems about this, how to restart the economic system. Usually when people promote the rule of the market, then talk about the economy. When people promote the role of the state, then talk about the public interest, public health, public education. So how to match this contradiction to predict the future development? Okay, I finish my comment here. Thank you.
Okay, wonderful comments. Thank you, Professor Lin Ka. So now I would like to invite two speakers come back to respond to the comments and questions from discussants. Professor Eggleston, please.
Thank you so much to Professor Lin and Professor Lin. I learned a lot from your comments, and we can't possibly address all the questions that have come up. Just some thoughts. That moving from healthcare to health is so important, thinking about healthy aging. And this is one reason why I think measuring outcomes is important, because we don't really measure what we care about as health outcomes. We measure what we spend, we measure doctor's visits and hospitalizations. But if we can measure health outcomes and figure out how to align incentives with the health outcomes we desire with equity, then we can provide incentives to reach out to the vulnerable and so on. So that's one reason why I think it's really important to work collaboratively on trying to measure what we really care about. If you pay for something else and not what you care about, and part of that is empowering communities and getting the voice of the communities you serve into the governance process and moving forward. There was a question, I think, about social and economic policies beyond technology. So I just wanted to mention that is related to what Alex said, maybe about DRG payment, or what Vivian said about healthy communities and reaching out with communities for prevention, because beyond specific focus on health care, we need to look at the whole life course investments from early age throughout the life course on prevention. And that requires thinking about history, institutions, payment incentives beyond just the technologies, right? I like to ask my students, which country has more of a tradition of caring for the elderly at home, Japan or Germany? Which country's long-term care insurance gives a cash payment for the family to take care of their elderly? It's Germany, not Japan. Why is that? You need to understand the legacy about, if you're just going to pay the family, that's kind of like not helping to alleviate the burden on the daughter-in-law. So it's part of a broader social, historical, path-dependent development beyond the technology when you think about the community and beyond. So I agree completely. We need to think about stewardship, and there are many important questions we have not yet answered. But I look forward to talking with you further about collaborative governance and other things. But I'll leave some time for Alex also to respond. Thank you all so much.
Yeah, thank you. Thank you, Professor Lin and Professor Lin for the wonderful comments. And to respond to Professor Linka's question, how do we evaluate, how successful post-COVID health policy changes are? I would like to draw from Professor Vivian Lin's earlier point. She made a distinction between health system and system for health. I think that's a great distinction. I think this pandemic has taught the mankind a great lesson, and I think moving forward in the post-COVID era, the old so-called success criteria we used to assess health policy changes may gradually lose their relevance. For example, the coverage of social health insurance, the increase or decrease public funding, and so on and so forth. I think moving forward, what I would expect is really a full integration of the fragmented healthcare systems. For example, Professor Liu, from La Trobe, just now, entered some great comments. He has observed that, the primary care system has been weakened because of the pandemic. And the system, the entire healthcare system in most countries is already so fragmented. And then the siloed practice is so resilient. And moving forward, long-term care, promotive care, preventive care, especially the preventive part of the care regime, and public health functions, and so on. I think the integration should be accelerated. I think that would be the way, that would be the sort of the vision health policymakers should develop. So in short, integration. Thank you.
Okay, thank you for each speaker and discussant. Thank you very much for your further response. We also have questions from the audience. So in order to save time, I choose one question to each speaker. He Jing asked a question to Professor Alex. Is it possible that these 5 functions have overlaps? So in her opinion, governance may also include some aspects of finance or regulation. If so, how to explain those overlaps? Professor He.
Thank you so much. That's a great question. If you look at the social science jargons, governance is one of the most abused words. It can mean everything, indeed. And here in my presentation, governance mainly refers to central level coordination, or that sort of stewardship functions. So when you actually use an alternative way of understanding governance, for example, how various stakeholders interact, how the government manages different interests and so on, I do agree with you. In terms of financing provision, there's a great deal of interaction from various stakeholders. Whenever the government wants to move on towards a vision, towards meaningful reform, they have to overcome resistance, really balance various interests. I do agree with you, and that requires lots of concerted governance efforts to reduce the barrier and move things on. But in this current paper, the word of governance is conceived in a narrow way. It mainly refers to stewardship by the state government. Thank you.
Okay, another question from Professor Lu Yi to Professor Eggleston. One of your slides calls for social and economic policies going beyond the technology advancement. Can you please talk a bit more about what social and economic policies shall be redesigned first?
Thank you. Yes, I touched upon that in my response. I wanted to make the point that it's not just about specific technologies where we need innovation, despite those being so important, like we've seen with the COVID-19 vaccine technologies and how much contribution to well-being. But we also see that there's incredible inequity in access to that technology. And that goes to the broader issue of social and economic policies domestically and globally, to be able to provide access to the vulnerable that wouldn't otherwise have that access. And so that's why I think we need social and economic innovations, implementation, if you will. Designing policy is great, getting the design right is great, but implementing it and enforcing the implementation and making it equitable, those are all challenges that require broader issues of social and economic design, if you will. And to think about what drives health, we think about social determinants of health, and you can't just look at medical care or one particular intervention without thinking about the broader social and economic context. So we need people working together to bring ideas about how to measure what real value is, and then to give that kind of evidence to policymakers. As Professor Vivian was pointing out, this crisis of having enough resources to devote is only going to get worse in some sense. We really need to think about what works and what really is bringing value and try to cut down on the waste. And in that regard, we need innovations in our social and economic policies just as much as we need in specific technologies.
Okay, thank you. We also have very good questions. For example, Professor George Liu asked about the primary care system. So anyone has some response to him? What's the role will a primary health play for improving health equity? Anyone has any idea? No? Professor
I'm happy to. I'll just pick that up. I mean, I think globally, for a long time now, the research, and Barbara Starfield was really the critical person on this, really demonstrates that you see much better health equity in countries that have strong primary healthcare system, and public financing makes a difference. So that's what the research, continually says. However, we get back to the political economy issue. And in most systems, it's the hospitals and the medical specialties and the pharmaceuticals that get the attention because that's where the money is. It's also where the corruption is because that's where the money is. So even when we look at, say, the 2009 health reforms in China, which I think many members of this audience would be very familiar with, and I worked on the 10-year review of it recently, we can see that there's huge increase in terms of government investment in primary healthcare. And we can see increased utilization, and we can see the increases in alliances between hospitals and primary healthcare. But when you put it into the larger system context, the increases in workforce has been much higher in hospitals. The utilization has gone up more in hospitals, and quite a lot of what sits behind the alliances between hospital and primary care is about capturing a market share. So I think primary healthcare can do a lot, particularly in the preventive and first contact space, but you cannot look at it separate from the dynamics of the rest of the system.
Thank you, Vivian. At last, Professor Lin Ka, do you have any brief concluding remarks?
Yes, I think this is a good topic to discuss COVID-19 from the public health, the perspective of the public health. And we hope that we will, from the public administration, will be more such a chance and to hear more such a kind of inspiring discussion. And thank you for the speaker and also for the discussion and the comments. Okay, thank you.
Okay, thank you. Thank you, all the speakers and discussants. In order to save time, we have to end this dialogue here. We have very important and very interesting presentations, as well as very wonderful discussion. Envisioning health policy in the post-pandemic, indeed, is a very, very important topic in the world today. So it does not end of the topic discussion, I think. We hope to have another opportunities to continue this dialogue with more health policy scholars. I also want to take this opportunity to thank Shilei, Hanjin, and Han Qi for your support. So thank you everyone for being here. Bye-bye. Thank you.